Hello, my name is Jim Moeller, and I am the Sports Medicine Fellowship Program Director at Henry Ford Health in Detroit, Michigan. I'm pleased to present to you today a lecture on pelvic avulsion fractures for the AMSSM Fellow Online Education Series. I have nothing to disclose regarding the content of this presentation. My goals during this presentation are to review the growth of the pelvis, review the pertinent anatomy of the pelvic region, review epidemiology of adolescent pelvic apophyseal injuries with specific attention to fractures, and to discuss specific mechanism, diagnostic testing, and treatment of pelvic apophyseal fractures. It is important that we remember that adolescents are not simply small adults. The musculoskeletal system is quite different in the growing athlete compared to the adult athlete. If we consider the growth velocity curve, children grow rapidly in the first 3 years of life, but in a rapidly tapering fashion. From 3 years to just before puberty, growth remains fairly stable at around 8 centimeters per year. Growth slows just before puberty and then rapidly accelerates. Growth centers are at greater risk for injury during rapid growth phases. The pubertal growth spurt usually occurs between ages 12 and 16 for most children, so this is a high-risk time of life for apophyseal avulsions. You all remember the regions of the growing bone, so we will not spend much time on this slide. I simply want to point out that the epiphyseal plate, or the physis, is an area that runs parallel to the articular surface of a bone and adds to length of the bone, where an apophysis does not run parallel to the articular surface, and instead of adding length, it helps with proportionality and shape. Both physes and apophyses are centers of enchondral ossification, but again, one adds to linear growth of a long bone, while the other helps maintain appropriate proportionality. Some ligaments will attach near physes and can lead to injuries of the physes during what would normally cause sprains in adults, whereas muscles and tendons often attach at apophyses. Growth of the pelvis matches the general growth velocity curve, with rapid bone growth until roughly the age of 2, and then slowing growth from 2 through puberty. Both males and females tend to have anthropoid pelvises during the young childhood time, but at puberty, the pelvic shape may begin to change. It is typically during the adolescent growth spurt when the apophyses begin to develop, and again, pelvic shape begins to change. After puberty, the female pelvis shape will change, where 50% of Caucasian women will develop a gynecoid pelvis, 25% an android pelvis, where 20% will continue to have an anthropoid pelvis. In black women, 50% will have an anthropoid pelvis, 25% android, and 20% gynecoid. So where are the apophyses of the pelvis? This diagram depicts the locations of the pelvic region apophyses: the iliac crest, the anterior superior iliac spine, or ASIS, the anterior inferior iliac spine, or AIIS, greater trochanter, lesser trochanter, ischial tuberosity, and pubic symphysis. The proximal capital physis is not included here, as that is going to add to linear growth and is not technically an apophysis, as we had discussed previously. Parvaresh and colleagues use CT scan to study age of appearance and closure of pelvic apophyses. It was found that the age of appearance of apophyses occurred in a very specific order in females and in males, although the order is slightly different when you compare the two genders. You can also see that the ages are quite different, appearing in as little as under 2 years or 4 years of age for the greater trochanter to as old as 17.5 to nearly 20 years of age for the symphysis pubis. The numbers seen here are the mean ages at the time of appearance. You can see, however, there is a wide range of ages at which these apophyses may appear both in females and in males. When they looked at the age of closure of the pelvic apophyses, Parvaresh was able to see that a very specific order was followed for males and females, and this order was the same in both genders, while there was a slight difference in the order of appearance between the genders. As with age at time of appearance, once again, we will see a wide range of ages for closure, both for females and for males. If we think about the musculoskeletal system in adolescence as a chain, thinking of the bone, the apophysis, the tendons, the muscles, the apophysis is the weak link. And so if we were just to pull on that system from end to end like a rope in a tug of war, and we expected the chain to break at its weakest link, the chain would break at the apophysis at certain ages. Now, as the apophysis matures, the tensile strength will increase, and eventually the tendon or the muscle will become the weak link. But this is why we see injuries like Salter 1 injuries of the lateral ankle and distal femur physis instead of sprains to the ATF or MCL, and why we see pelvic avulsion fractures. Pelvic avulsion fractures occur when a sudden muscle contraction overpowers the tensile strength of the apophysis. It's important for us, therefore, to understand where muscles attach in this system. If we go back to our prior diagram and add the muscular attachments, what we will find is that the abdominal muscles attach onto the iliac crest, the sartorius attaches onto the ASIS, the quadriceps onto the AIIS, gluteal muscles onto the greater trochanter, the iliopsoas onto the lesser trochanter, the ischial tuberosity is the attachment point for the hamstrings, and then the adductors attach onto the pubic symphysis. This helps us understand the directionality of displacement as well. For example, the sartorius is going to be pulling the ASIS inferiorly, and that would be the direction of displacement we would expect to see in an ASIS avulsion fracture. So let's move on to the epidemiology of injuries in these regions. Apophyseal injuries are most commonly due to sport participation, and they could include just simple irritation such as apophysitis, but fractures can occur as well due to direct trauma or due to avulsion, as I have mentioned earlier. Sport participation is the #1 cause of pelvic apophyseal avulsion injuries. The mechanism of injury is running and sprinting. Worldwide, we note that soccer is the #1 sport that causes this type of injury, and since the primary activity in soccer is running and sprinting, this would make sense. We find that males are more commonly affected than females at a ratio of roughly 2 to 1, and that's true when you look at all of the data regarding epidemiologic studies on pelvic apophyseal fractures that are available today. When we discuss sport in particular, we note worldwide that soccer is the #1 sport. If you consider the 2 largest United States-based case series, these are the sport areas where we most commonly see pelvic apophyseal avulsion fractures. Soccer, or what the rest of the world calls football, track and cross-country running, and then American football. A large Italian study showed soccer, gymnastics, track, and tennis to be the most common sports, but this study was based out of an Olympic training cohort, so there would be no American football represented. Considering the data that was presented by myself and my partner Lisa Galasso early this year, using our United States cohort in a small community practice, once again, soccer was the #1 sport in which we saw pelvic avulsion fractures, with males in the darker blue outnumbering females by quite a wide margin. And again, track, then American football, running for recreation, followed by baseball, basketball, and so on. You can see that some sports are only represented by males and females in the injury cohort, and that's because certain sports are specifically played by males and females in the United States, such as baseball played by males and softball played by females. In the adolescent population, in the state of Michigan, which is where I'm from, males do not play volleyball, although this is changing. But again, that is why you will see that only females are represented in the volleyball component of this cohort. Moving on to mechanism, we already mentioned running and sprinting being the number one mechanism, but kicking was number 2, and falls were number 3. Again, looking at the cohort that we were able to report on out of our institution, beyond running, sprinting, kicking, and falling, performing the splits, such as in gymnastics or cheerleading, jumping and landing from a jump, tackle, and this was usually football tackling, American football tackling, not soccer tackling. Basic training, lunges, and so on were the causes of injury. Most athletes present with a sudden onset of pain in the pelvic region, again, usually during sport participation. And you'll often read about a pop being felt or heard at the time of injury. In our group of 242 athletes, 97.5% of the injuries took place during sport participation. A pop was only heard or felt in 34%. Other components of the presentation included various abilities to bear weight on the injured side. Many were able to bear weight, but others could not. People often had pain with walking and doing other normal daily activities such as climbing stairs, and certainly attempts at sport activity were often painful, which is the reason for the visit. Various clinical findings at the time of presentation were noted, but most commonly, pain was noted at a very specific area of the pelvis. Weakness was noted at the muscle group, which attached to that area in 85%. And the weakness may have been more pain-driven than true weakness. It's hard to know. Painful range of motion was present in less than 50% of the athletes who presented with this injury, and limited range of motion around 30%. Less than a quarter of them were limping at the time of their presentation. When you consider the location of the injury, we find that the anterior inferior iliac spine, ischial tuberosity, and anterior superior iliac spines are the most common locations for injury. And this is the order of commonality when you consider all of the major studies of epidemiology of this type of injury. When you take a look at individual publications regarding this injury, you'll see some variation in the location of injury. For example, in our study, the anterior superior iliac spine was the most common area of injury, but this is not true across the board. AIIS leads the pack, although this is bolstered by the findings of a single large study. The Schuett study, which was a U.S. sport population, reported nearly 50% of their cases to be AIIS avulsions, which is significantly higher than in any other of the larger reports, in which most show the AIIS to make up about 20 to 25% of the cases. Another interesting note is in the Rossi and Dragoni paper from Italy, which I had mentioned earlier. That was the one from the Olympic training cohort. They had 7 cases of pubic symphysis avulsion. This is the only study reporting avulsions in this region. Particularly interesting when the average age of the patients was 13.8 and the pubic symphysis apophysis usually doesn't even appear until the age of 17.5 to 20. Ours was the first report of a greater tuberosity avulsion, and this was due to sport in an 11-year-old who was injured during a skateboard fall. It took 10 days from the injury to presentation and 24 days of treatment for that athlete to improve. When you look at the data, again, from the cohort that we reported on, you'll see that the anterior superior iliac spine was the most common area injured, with anterior inferior iliac spine and ischial tuberosity being roughly equal at about 25% of the cases each. X-rays will detect the defect in over 90% of the cases, and so a good X-ray is often all that's necessary to confirm the diagnosis. MRI or rarely CT scan was used to diagnose the rest of the injuries in our cohort, but those studies were never ordered by the sports medicine physician from our clinic. Those were ordered by other physicians prior to the initial presentation to our clinic. I would like to review some X-rays with you at this point. So when you obtain X-rays and you're looking for the injury, this is what it may appear like. On the left-hand image, you will see an anterior superior iliac spine avulsion with inferior displacement due to the pull of the sartorius. On the right-hand side, you will see an AIIS avulsion, again with displacement inferiorly due to the pull of the quadriceps muscles. If we move on this slide, the far left image is of an ischial tuberosity avulsion fracture from traction of the hamstrings. The central picture is a lesser trochanter avulsion due to forceful traction of the iliopsoas muscle, therefore leading to a proximal displacement of the fracture fragment. And then on the far right, an iliac crest avulsion. When we compared the location of injury based on gender, we were able to show that males were significantly more likely to avulse at the AIIS compared to females, where females were much more likely, and statistically significantly so, to avulse the iliac crest compared to males. ASIS, ischial tuberosity, and lesser trochanter avulsions were roughly equal in incidence between males and females. When we analyzed age at the time of injury, the mean age at diagnosis for all members of the cohort was 14.7 years, with a range of 9 years of age to nearly 20 years of age. The mean age at diagnosis for males was 14.87 compared to 14.31 for females, and this difference was statistically significant. Females were consistently younger than males at time of injury at all sites. When comparing age at time of injury between the genders at individual sites, all areas demonstrated a p-value of less than 0.1, but only the age differences at the ASIS and lesser trochanter showed statistical significance. We then compared age at time of injury, this includes both male and female, of one site to all other sites. We found that AIIS and IT avulsions occur at a significantly younger age when compared to all other sites, while injuries at the ASIS and iliac crest occurred at significantly older ages compared to all other sites. And this is consistent when you think about the timing of closure of the growth areas as we discussed previously. We then looked at treatment for these injuries. Nearly 100% of the athletes were advised to rest and were removed from their sport for a period of time. Ice was recommended for nearly all athletes as well, as was over-the-counter medication use for pain control. Just under 50% were advised on a home exercise program focused on maintenance of range of motion and strength to a pain-free level. Less than 30% were placed on crutches. About 25% were recommended heat. Roughly 20% were recommended formal physical therapy. An orthopedic surgery consultation was advised in 8 cases, about 3.3% of the total cohort. The mean duration of treatment, which was measured from the time of presentation at our sports medicine office to the time they were cleared to start their progression to return to sport, was nearly 7 weeks, with females taking slightly longer than males, although this difference was not statistically significant. 15 patients were lost to follow-up, but of the 227 followed to resolution, all were cleared to advance to return to sport. We did not perform additional follow-up after they were cleared for beginning their return to sport protocol, So it may have taken an additional 4 to 6 weeks for them to actually participate in a game. So these numbers are simply based on the time from initial presentation to time that they were cleared for their return to play protocol. Looking at duration of treatment for individual sites, there was a fairly wide range of amount of time it would take to clear them for return to play. Iliac crest injuries were cleared at a mean of 39 days, where the ischial tuberosity took 52 days on average, with lesser trochanter, AIIS, and ASIS falling in between. What you see here are box and whisker plots showing the duration of care for individual regions of pelvic avulsion fracture. On this plot, the lowest bar represents the minimum value. The bottom line of the box represents the 25th percentile, and the line in the center of the box is the median. The geometric shape inside the box is the mean. The top line of the box is the 75th percentile. The highest bar is the highest observation within 1.5 times the 75th percentile, and the symbols above are considered to be outliers. We actually had one case where an athlete presented 1 year after their injury, and that type of person, for example, would be considered an outlier. Despite the range of times noted in duration of treatment, none of these reach statistical significance when compared to another. Our conclusions from our studies and from reviewing the other available studies is that these injuries take place due to sport participation, with soccer being the #1 sport worldwide. In the United States, soccer, followed by track and cross-country participation, and then American football were the top 3 sports. Running and sprinting activities were the #1 mechanism, followed by kicking and falling. Males were more commonly affected than females at a ratio of roughly 2 to 1. And males were older than females at the time of injury by roughly 6 months. The anterior superior iliac spine, ischial tuberosity, and anterior inferior iliac spine are the most common locations. The ischial tuberosity is most common when you combine studies, but much of that is from a single study. Remember that iliac crest injuries are significantly more common in females, and AIIS injuries are significantly more common in males. Average treatment time ranges between 6.5 to 7.5 weeks in most cases, and males roughly will take 1 week shorter for healing than females. And again, that's consideration of timing from initial presentation and diagnosis to the time at which they were cleared to start their return to play activities. From this data, we felt like we answered some questions regarding epidemiology, treatment, and duration of return to play. But this information also caused other questions to arise, which we thought we should be looking at in a different way. We noted that the average time to diagnosis from the time of injury event was nearly 3 weeks, and we didn't know why this was. And we wanted to know, did this actually even matter? If this is an acute injury event, shouldn't kids be presenting early? Are there factors associated with delay in making the diagnosis? And since we already saw that kids were able to get better with simple rest, pain control modalities, and maintenance of motion and strength, would a delay in the diagnosis even lead to a delay in recovery and a delay in return to sport? Dr. Galasso had worked with me on the original paper, but she had graduated from medical school at that time and moved on to her residency. So I wanted to take a look at that cohort that we had reported on previously and try to determine what was the time to diagnosis from the injury event, the duration of treatment, and then the duration of return to play advancement for pelvic apophyseal fractures. And again, that would be from the time of injury event to the time they were cleared, not just from the time they were diagnosed to the time they were cleared. We wanted to see, was there differences by age, by location, by sport, by gender? Were there specific reasons for delay in diagnosis? And were there differences based on the timing of injury? Now, the definition of delayed diagnosis is not agreed upon because this has never really been looked at in this type of injury setting. Certainly in other types of injuries, for example, the scaphoid bone, if you fracture the scaphoid, a delay beyond a certain amount of time will lead to an increased risk of non-union as opposed to early diagnosis and treatment. But again, we don't even know what the definition of delay is when we talk about pelvic apophyseal fractures. So the next thing I did was I took that same cohort of patients and reviewed cases of AIIS, ASIS, iliac crest, and ischial tuberosity avulsions. I did not include the greater and lesser trochanters because the numbers were so small. I felt that we could not get a meaningful statistical comparison using those numbers. And we divided the timing of diagnosis in a couple of different ways. One, we basically divided the groups into weekly intervals. And secondly, we then took a time cutoff point and looked at all athletes who were diagnosed before that time cutoff compared to all those diagnosed after that specific time cutoff. Because of this, we had 225 total cases, and 208 were followed to clearance for return to play activities. When we looked at the groups in weekly intervals, it would be people diagnosed in the first week, so 0 to 7 days, the second week, 8 to 14 days, the third week, 15 to 21 days. The fourth week we considered from 22 days to the end of the first month, which would be 30 days. And then we looked at everybody from 31 days and beyond, and we just labeled them groups 1 through 5. And then what we did for the cutoff points, we looked at those diagnosed before and after 2 weeks, before and after 3 weeks, and eventually we even went out to before and after 4 weeks for timing of diagnosis. Analyzing groups based on timing of diagnosis revealed that under half of them were diagnosed within the first week, and under 60% were diagnosed by the end of the second week. As you moved on in time, more and more patients were diagnosed, as one would suspect, adding roughly 30 patients per week from the original group. Interestingly enough, 30 of our patients were diagnosed after 1 month from the injury event. This chart compares the location of injury when you consider the time to diagnosis, which would be the time from the day of injury to the day of diagnosis, the duration of care, which would be timing from the diagnosis to their clearance, and then we looked at the combination from the time of their injury to the time of their clearance, which we consider the DRTPA, or the duration for clearance for return to play activities. And you can see that when you look at the AIIS, the ASIS, and the iliac crest, the average time to diagnosis was relatively short in comparison to the ischial tuberosity. Again, the duration of care we spoke about earlier, but when you consider the duration from the time of the injury event itself to the time that they were cleared for return to play, that it was roughly 2 months in most cases, but the ischial tuberosity was nearly 3 months before clearance for return to play activities. And this stood out, and this difference was statistically significant when you compared it to the other locations. Ischial tuberosity injuries appear to take much longer duration from date of injury to clearance for return to play activities. And again, compared to all other areas, there was statistical significance. When you think about it from a sport perspective, and this is a very busy slide, so I don't want you to focus on the numbers. But again, we're looking at time to diagnosis, duration of care, and duration for clearance for return to play activities. What I've highlighted here is that basketball stands out as the sport that takes the longest time from the time of injury to the time of diagnosis. Now, dance and ballet also has a long duration for the diagnosis itself. So there was a significant difference in time to diagnosis for football, basketball, and dance ballet athletes when you compare to athletes in baseball and softball, which had the shortest time from injury to diagnosis. Although our track, cross country, and running athletes were diagnosed at a mean time only slightly longer than baseball and softball, this did not translate to significant differences in time to diagnosis between those sports and other sports. Females were more likely to experience a delay in diagnosis compared to males. Nearly half of the males with pelvic avulsion fracture, 46%, were diagnosed in the first week after injury compared to 37% of the females. At week 2, there was still a wide margin, with 61% of the males having been diagnosed compared to less than 50% of the females. By the time of the 3rd week, this had basically evened out, where both males and females saw 70% of the cases diagnosed. There were no statistically significant differences in timing of diagnosis, duration of treatment, or duration for clearance for return to play activities between females and males. When you look at those 3 parameters, comparing right side versus left side injury, again, there were no statistically significant differences. So clearly, ischial tuberosity injuries are delayed compared to other locations. Basketball players have a delay compared, say, to baseball players and softball players, and there is no difference when you look at gender or side-to-side injury. What about history of a pop? Remember that roughly 1/3 of our patients experienced a pop at the time of injury, and 2/3 of those patients were diagnosed within the first week. Patients diagnosed at 15 days or greater were significantly less likely to have experienced a pop than those who were diagnosed in the first 2 weeks. And so the history of a pop at the time of injury will actually reduce the likelihood of delay when compared to a history of no pop. This makes sense since the sensation of a pop at the time of injury with significant pain and disability would likely lead to earlier seeking of care compared to those who do not experience that type of history. So clearly we were able to see some factors associated with delay in diagnosis, such as location and sport, and one factor that led to a faster reporting or certainly a faster diagnosis for some athletes, which would be the presence of a pop at the time of their injury. But this couldn't be the only explanation. So we wanted to figure out the reasons for delay in diagnosis. And again, we look at our divisions of 14 days, 21 days, and 28 days. So the 14-day cutoff would be anybody diagnosed before 14 days versus all of those diagnosed after 14 days, and so on. And what we found was that the most common reason for delay in diagnosis was delay in seeking care. The patient or the family simply decided not to come in and be evaluated. We were the first provider to look at the athlete after their injury event and made the diagnosis at the time of their initial evaluation. And so that choice not to come in for evaluation was the number one choice. But you can see that as weeks went on, that number declined as you would expect. Now, some athletes were misdiagnosed. They were seen by another provider and diagnosed with a hip flexor strain, for example, when they actually had an ASIS or an AIS or potentially a lesser trochanter injury. And you can see that was the case 21 times when you look at a 14-day cutoff. But then as you move to a 21-day cutoff, 10 more patients were identified and 4 more patients in the next week. Sometimes the patient was but again, in that case, no x-rays were obtained. They were simply diagnosed with a hip flexor strain with no x-rays. And as we said before, x-rays are vitally important to make this diagnosis. Some people were diagnosed with hip strain and they had x-rays done, but the x-rays were misread by the initial interpreter. And in that case, that number stayed fairly flat because, again, if you had x-rays already, then you believed what you were told and didn't seek treatment potentially. You can see, though, interestingly for me, is that the number of people who were diagnosed as having a hamstring strain, so this would be an ischial tuberosity avulsion fracture, had no x-rays obtained. The number was 13 people at the 14-day cutoff, 13 people at the 21-day cutoff, and 12 people at the 28-day cutoff. And so these patients remained in pain, but again, even without x-ray, they believed their initial diagnosis and continued to suffer the ills of a ischial tuberosity avulsion fracture with pain and inability to return to sport. So again, in some cases, we were able to see that other providers were involved in care of these patients, but the diagnosis was missed. So who did these patients see? Here's a list of the providers that actually saw patients that were eventually diagnosed with this injury, and they were either diagnosed with a strain or some other type of injury. Primary care physician being the number one provider that saw these patients initially without having the appropriate diagnosis made. And you can see that in some cases, some athletes actually saw multiple providers, for example, a PCP and a physical therapist, or they saw a PCP and an orthopedic surgeon, and so on. And so again, just because they seek treatment doesn't mean that the diagnosis is made appropriately. I believe that educating other providers regarding this type of injury is important so we don't miss these types of injuries in other settings. Big question, though, is does delay in diagnosis even lengthen the time away from sport? Does it really matter? If we delay the diagnosis by a week or 2 weeks, are we really making a negative difference with regards to the patient's ability to return to their activities? If we go back to dividing this cohort based on timing of their diagnosis in weeks, so again, group 1 would be in the first week, group 2 would be diagnosed in the second week, group 3 in the third week, and so on. And then look at their time to diagnosis, duration of care, and the duration for clearance to return to play activities. We were able to see some statistically significant differences. Now remember, in group 1, that would represent just under 100 patients. Each of the other groups would represent roughly 30 patients each. You'll notice in the column for time to diagnosis that the mean falls within the timing that we reported. When you look at the duration of care with the eyeball test, you would say that there should be no statistically significant difference in the duration of care between each of the groups. You would be absolutely correct with this eyeball test. There was no statistical difference in duration of care between groups, but there were significant differences in duration for clearance for return to play activities between the groups, which started when the diagnosis was delayed beyond 3 weeks. Group 1 athletes, or those diagnosed within the first week, had a significantly shorter duration for clearance to return to play activities compared to the group 4 athletes, which would be those diagnosed between days 22 and 30, and group 5 athletes, which would be those diagnosed beyond 1 month from their time of injury. Those diagnosed in group 5, which would be, again, beyond 1 month from the time of injury, had a statistically significant longer duration for clearance to return to play activities compared to all groups, in fact. And while comparing group 1, 2, and 3, there was no statistically significant difference for duration for clearance to return to play activities, an athlete would argue that a difference of nearly 20 days is a significant difference, especially when they're trying to get back into a season of play. And so any athlete would prefer to be diagnosed early if their clearance would come at 7 weeks as opposed to coming at 9.5 weeks. So at what time point can we define this group of injuries to be a delayed diagnosis? By the data here, we can certainly start to see changes in those diagnosed after 3 weeks compared to those diagnosed in the first week. So I compared data based on specific time to diagnosis cutoffs. This is just a graphic depiction of what the prior chart had shown, again, showing that if you're diagnosed in the first week, your time to return to play activities is going to be significantly shorter than if you're diagnosed past a month. But again, I want to get into the comparison regarding time cutoffs, looking at this information. So this chart uses time cutoffs. And as I mentioned before, a 14-day cutoff would compare all of those diagnosed up to day 14 versus all of those diagnosed from 15 and later. The 21-day cutoff would be those diagnosed from day 0 to day 21 versus day 22 and later, and day 28 following the same type of thought process. If you were diagnosed in the first 2 weeks, your duration of care was roughly 46 days compared to 51 days if you were diagnosed after 2 weeks. And that difference was not statistically significant. However, when you look at duration for clearance for return to play activities, those who were diagnosed in less than 2 weeks were cleared around 51 days compared to 93 days for those diagnosed after, and that was statistically significant. When you look at the 28-day cutoff, once again, the duration of care was not significantly different, but the duration for clearance for return to play was again statistically significant, nearly twice as many days for return to play. And when you use the 28-day cutoff, again, there was no statistical difference, although it was approaching that. But again, it was over twice as many days to return to play. And so I think by this information, we should look at 2 weeks as being a delay in diagnosis for pelvic avulsion injuries if we want to make a difference for people with regards to getting them back to what they wish to do quickly and safely. This slide simply puts that prior table into more of a graphic depiction. Some people, like myself, are better with pictures than with words. And so, again, if you look at that top group, that's using the 2-week cutoff. And so if you're diagnosed within the first 2 weeks compared to after the first 2 weeks, there's a significant difference with regards to timing for return to play, which increases if you make the cutoff at 3 weeks, and even more so if you make the cutoff at 4 weeks, which again leads me to believe that using a 2-week standard for consideration of the definition of delayed diagnosis for pelvic apophyseal fractures would make sense. And if you ask any athlete if they can return to play 6 weeks faster just by being diagnosed at an earlier time, they would certainly want to be diagnosed early. So my conclusions, based on the information reported here, is that less than half the cases of pelvic avulsion fracture are diagnosed within the first week. In fact, we found that 43% were diagnosed at 1 week, moving up to 57% around 2 weeks. And then by 3 weeks, roughly 70% had been diagnosed. And again, that's in the cohort of patients that we were looking at. And the 70% was roughly equal for male and female at that time, although females were much more likely to have a delay compared to males, but not reaching statistical significance. Patients who experienced a pop at the time of injury were more likely to seek early care. Basketball athletes experienced the greatest delay to diagnosis, but this only represented 11 patients in our cohort. When you compare gender, while males are much more likely to experience a pelvic avulsion fracture compared to females, males and females were delayed in diagnosis at roughly the same rate. We found that delay in seeking care on the part of the patient and the family was the number one cause for delay in diagnosis. However, we did find that many patients did seek treatment and were misdiagnosed, and I think, again, education of our colleagues could help in allowing for more rapid diagnosis in these athletes with pelvic apophyseal fractures. Regarding time to diagnosis and location, people who experienced an ischial tuberosity fracture were much more likely to have a delay in diagnosis to those in all other locations. And again, many of these cases, we saw 13 cases, were diagnosed as strain without even x-rays having been performed. And perhaps it's simply because people are comfortable with the thought of hamstring strains that many of those patients, in fact, almost all of them, continued to go undiagnosed until they got past the 30-day mark, at which point, as we have seen, the duration for clearance for return to play activities goes up significantly if that diagnosis is delayed beyond 1 month. Which is our final conclusion, is that duration for clearance to return to play differences can be significant due to diagnostic delay. And that's despite the fact that duration of care, which would be from the time of diagnosis to the time for clearance, did not really statistically change between groups. I hope you have found this information to be helpful. Here is a list of references from this lecture. I will leave you with this view of the skyline of the city of Detroit, and thank you very much for your attention.